Good morning. My name is James Stanger, and this morning I'd like to do a short video on natural cycle IVF when you have to do an emergency collection. The question is, when should you denude and fertilise the oocyte? Okay, so just by way of introduction to people that may not know a great deal about natural cycle IVF, if you're an IVF staff member, you might like to make a comment that interest in natural cycle IVF has surged because unstimulated in vitro matured oocytes are thought to possess a higher potential for fertilization and implantation. However, the efficacy of natural cycle IVF is limited by high cancellation rates due to spontaneous surging and premature ovulation, which occurs in about 30% of cycles. Because early ovulation occurs commonly during natural cycle IVF, emergency oocyte retrieval in natural cycles is frequently required. As a result, the timing of oocyte retrieval can be unpredictable, with some oocytes being retrieved in the early afternoon. That's a bit complicated. But if you're a client, a person coming seeking IVF treatment, you'll probably find most clinics will not discuss natural cycle IVF because it creates a lot of complications for the clinic, and they'll give you a lower pregnancy rate. But natural cycle IVF confers several advantages, including minimizing the risk of ovarian hyperstimulation syndrome, significantly reducing the costs, avoiding the need for stimulatory medications, and enhancing the physical and emotional ease of patients, all of which allow for more frequent cycle repetitions. And in fact, one of the key things about natural cycle IVF is you can do it month after month after month, and it's a bit like just a quick visit to the doctor. Moreover, natural cycle IVF is associated with a lower risk of adverse perinatal outcomes, such as low birth weight compared to fresh transfers following ovarian hyperstimulation. Natural cycle IVF also only usually has one or two eggs, and as a result, more often leads to no fertilization or no transfer. Okay, so in natural cycle IVF, a single follicle is allowed to grow, although sometimes additional follicles can be encouraged by the use of clomiphene. The follicle size and endocrinology are monitored, and a dose of HCG ovulation dose is given when the follicle reaches about 7 to 18 millimeters and before the LH surge. So for those people sort of unfamiliar with it, as a follicle grows, it starts to produce estrogen in increasing amounts. This is caused by a transient rise in FSH, but as the estrogen rises, that causes the FSH to fall, so you only ever get one or two follicles. And at some point in time, the follicle is producing huge amounts of estrogen, and normally, up to maybe 1,000 picomoles per liter. And then all of a sudden, that triggers a response in luteinizing hormone, this blue line, and this hormone is responsible for inducing ovulation. It takes about 36 hours. It starts off a very slow rise, then rises very, very quickly to some peak, and then falls away. And at that time, ovulation can occur anytime from 36 to 44 hours from this point here. And as soon as the follicle starts to be exposed to luteinizing hormone, the estrogen starts to fall. That's an indication there's LH there. And just prior to ovulation, the progesterone starts to rise. So the aim of the game is to monitor the rising estrogen with blood tests and scans. And when you think you're getting close to this point, you give the trigger, and that means that you then start to initiate ovulation, and you can schedule the pickup in a normal case 36 to 37 hours after the injection. So that's the sweet spot. But in about a third of the cases, the estrogen starts to fall, the LH starts to rise before you've had a chance to give the LH dose, or the dose of HCG. So if the HCG has been given before the LH surge has started, then the egg collection can be planned for 36 hours later with minimum confidence. So with maximum confidence, the follicle will not have ruptured. Although there's always a chance that you'll aspirate the follicle and not recover the egg. You can detect if ovulation started by measuring the estrogen and progesterone 12 hours later. If the estrogen has not fallen and the pH remains low, then the LH surge has not started and all is good. However, if the estrogen has started to fall and the progesterone started to rise, that means the surge has started. This means the follicle may or may not always have ovulated before the egg if you set the egg recovery at the normal time. The response then is to schedule the egg recovery earlier than planned. This is an emergency. This is subject to the paper. These are called emergency oocyte retrievals and subject to this video. This paper also tells a bit more about oocyte competency and about oocyte aging. So in standard IVF, drugs are given to stop ovulation, so stimulation can continue until a good crop of follicles are available. In natural cycle IVF, ovulation is triggered before the natural time of ovulation. This means that the follicle and the egg it contains may not always be quite ready to be fertilized and develop. That is, that some eggs, when collected, may not be fully mature. In natural cycle IVF, where ovulation has started before the trigger, then the follicle theoretically is mature, but because the collection has been rescheduled, the egg may not be ready to be fertilized when it's collected. It's all rather complicated. There's one reason why people don't like doing natural cycle IVF, because it is complicated for the client. It can be really quite a uncomplicated process. So, subject of this paper from a set of Chinese authors in BMC Pregnancy and Childbirth, published November 2025, and it was determined the most effective insemination protocol for patients undergoing emergency oocyte retrieval in natural cycles, comparing the immediate denuding and ICSI of the eggs against culturing all the eggs overnight before then doing the ICSI the next day. So, two options after the trigger. You'd always check for serum FSH, LHE2 and PROG. 10 hours after the trigger, that's you do the trigger at night and then the blood test in the morning. If the estrogen has decreased by more than half, as it's big fall, the retrieval is immediately performed that afternoon. If the estrogen has been reduced by 1/3 to 1/2, so it's only just started to drip a bit, the retrieval is planned to take place after 2 p.m. on the same day. If the estrogen is decreased by less than 1/3, the retrieval is deferred until the following morning. Okay, so option E is retrieval is before 2 o'clock, the eggs are denuded, mature eggs are rejected, immature oocyte eggs are cultured overnight and ICSI'd the next day. Option L, the oocyte retrieval is after 2 p.m. and the oocytes are cultured overnight and then denuded and ejected the next day. So the results. In this study, the authors found no significant difference were found in overall embryonic development of clinical outcomes between group C and E. However, the overnight culture group exhibited high fertilization rates, 87% compared to 77%, and group E achieved far higher embryo quality, 52% were good embryos compared to 40%. The oocyte utilization rate was similar between the two, and the live birth rates were similar, 13% to 12%. So the conclusion were these two protocols were both feasible in patients undergoing natural cycle IVF where there was an emergency oocyte retrieval. The group E achieved better fresh cycle pregnancy rates. Group L showed a higher fertilization rate with reduced manipulation. Okay, so let's go look at the data. So this is the embryology data. This is the emergency and pick up straight away. These are ones with cultured embryos being cultured overnight. And you can see, obviously, that divided two groups, the ones that were fully mature, that's 100%. So this is where you do the pickup fairly early morning so that you're very close to ovulation. And if the eggs that are mature, fertilization rate percent 75%, which is similar to IVF. Fertilization rate with 2PN, that's a little bit lower than you would normally expect. But half those embryos were of good quality, and they used about 37% of the oocytes. For the embryos that eggs have been cultured overnight, nearly all of those eggs were mature the next morning. Slightly higher fertilization rate, significantly higher. But the fertilization, the normal, that's the 2PN fertilization rate, was fairly similar. So by culturing overnight, you have some eggs that were mature and they sat around overnight unfertilized, that's their age slightly. And then you have a whole lot of immature eggs that have matured overnight that look like 2PNs you inject, but a lot of those have an abnormal fertilization. So basically, the 2PN fertilization rates are fairly similar, but there are more high quality embryos in the early morning pickup than the overnight culture, 54 to 40%. But the utilization rate at the end of the day, 37% to 32%, was fairly similar. So there are trends here that suggest that if you are very close to ovulation, when you give the HCG and you do the pickup that morning, the eggs that you collect, which you already have a polar body, so they're mature, they actually do quite well. But even here, you're only getting 55% of all the eggs you collect that are mature will develop into high quality embryo 2 days later. And looking at the pregnancy data, you can see there's not a lot of cases here, 48 compared to 38. Really, it's not, but then you find most clinics don't do a lot of natural cycle IVFs. The fresh clinical pregnancy rate, 22%, 10 out of 14, compared to 7%. So the pregnancy rate was fairly disappointing, 10 out of 44 compared to 3 out of 38. Not significant, but almost. But the thing that caught my eye was this problem here, this miscarriage rate, 40% for both of them, which were quite low. So the live birth rate was 13% for the group where you did the emergency pickup straight away, and 5% if you cultured the embryos overnight. So quite really, that's not a good option. And overall, because some embryos were frozen, some weren't, this group here had a poorer FET rate than the overnight culture. So the overall, the total live birth rate, which is the only really important thing, 16% for the really good eggs, but add in the ones you cultured overnight, so it ends up being 13% for the emergency pickups where you do them in the morning, and 12% where you culture them overnight. So despite all this data, at the end of the day, is that there's about 1 chance in 8 of a pregnancy, regardless of when you culture the eggs overnight or inseminate them straight away. And I thought this was interesting. The gender ratio, male to female, 7 to 3 and 6 to 3. Not significant, but I actually don't know that has any relevance, but that would be interesting to look at in other studies. So just to go back and reiterate, the thing that caught my eye was the clinical pregnancy rate, where if you're given the HCG injection, just where the LH surgeon has been already well undergoing, you do the pickup that morning, you actually are very close to a perfect situation. The pregnancy rate's 1 in 5 clinical rate, but you still have this high miscarriage rate of 40%. So really, you only end up with 6 out of 48, which is still pretty disappointing. And it's not that dissimilar, but still better than if you just culture the eggs all overnight. And once again, just summarizing the data, I think the important thing for me here is the miscarriage rate. Miscarriage rates, half of those are due to oocyte aneuploidies, and the other half are to do with implantation. So suggesting these natural cycle IVFs, a lot of these eggs, particularly these ones here, have an increased level of maternal aneuploidy. Okay, so just a few comments before I finish. The immediate pickup exhibited several advantages. That high quality embryo production, the higher proportion of high quality embryos in this group supports the critical importance of timely fertilization. That is, the eggs when you collect those eggs, they're almost at the ovulation point, and you can fertilize them straight away. And delaying that associates with poor embryo quality associated with oocyte aging. Where you did the pickup late in the afternoon and cultured them overnight, this group had far better fertilization rate, but less embryo quality. That is, that if you allow immature oocytes the benefit of culturing overnight, they produce a polar body inject. Even though they fertilize, the embryo quality is not all that spectacular. So just to summarize, these two protocols are feasible for patients in natural cycle IVF undergoing emergency oocyte retrieval. Group E achieves slightly better results in terms of the fresh transfer rate, and the overnight culture group showed a higher fertilization rate with poorer pregnancy rates. I just wanted to finish There's another really good reference, the role of natural cycle IVF in ART, published in 2019. It's a really good paper. And the benchmark for this, and I think I'll do a separate video on it, but I wanted to point out in this report, the standard pregnancy rate per initiated cycle is 10 to 15%. But the key thing here is this is the initiated cycle, and in IVF, in natural cycle IVF, about 30% of all cycles are cancelled. So in fact, the pregnancy rate per transfer will be higher. And in that paper, they summarised the success rate of natural cycle IVF per initiated cycle is significantly lower than conventional IVF. But with consistent monthly natural cycle treatment, which allows about 3 cycles in the same type period as one IVF cycle, that's actually more, the success rate per unit time is only slightly reduced. With low responders, the effectiveness of natural cycle IVF is higher than conventional ones, and basically older women with a high ovarian reserve benefit more from conventional IVF than natural cycle, but older women with a poor ovarian reserve, they may benefit from natural cycle IVF. Okay, so my name is James Stanger. I'm an embryologist with more than 50 years experience. I need to point out I'm not a medical person, and this information is not medical advice, but hopefully it may help you in knowing what questions to ask about your treatment with your doctor, and maybe help in understanding the advice that you receive. If you like what I'm doing, press subscribe, make a comment, and tick like, and it's good. And just one last word from my sponsor. I also run an online EQA program in IVF, andrology, and embryology. And the benefit for clients, the benefit is that if the staff who are looking after your embryos are participating in EQA programs such as mine, then it tells you they are under constant review and assessment and gives you far more confidence in their competency. And I think I'll thank you for your time. I understand IVF is a personal journey that involves the action of many different techniques and staff, and it helps you understand all aspects of that journey. I hope this information may be of value. Tell other people how good this video is, and I think I'll leave it at that. Thank you for your time.